Well, welcome everyone to Ask the Experts, the pulse on progress, insights into ovarian cancer. I'm Jennifer McClendon, Senior Manager of Education and Mission Programming here at the NOCC, and I'm so glad to be joined by Dr. Michael Bookman, Director of Gynecologic Oncology Therapeutics at Kaiser Permanente in Northern California, and a member of NOCC's Medical and Scientific Advisory Board. Dr. Bookman, it's always an honor and so glad to have you here.
Oh, I'm happy to join. Looking forward to it.
Wonderful. Thank you. Yes. Before we get started, I just want to let everyone know this program is being promoted alongside our wonderful colleagues at Share Cancer Support. Share is a wonderful national nonprofit that supports, educates, and empowers anyone diagnosed with breast or gynecologic cancer and provides outreach to the general public as well about the signs and symptoms of ovarian cancer because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For information about their upcoming webinars and groups and helplines, you can visit their website at sharecancersupport.org. And I also want to thank our generous partners, GSK and Merck, for making this program possible. So, this Ask the Experts program is a concise 30-minute program where we will aim to provide you with timely information about ovarian cancer. And today we'll be discussing the latest research and developments in the field of ovarian cancer, including highlights from the recent conferences, the Society for Gynecologic Oncology and ASCO, the most recent one. So, as many have recently said, Dr. Bookman, we are truly in an exciting area for ovarian cancer and ovarian cancer treatment and research. Numerous groundbreaking discoveries. Physicians can now tailor personalized treatments more effectively. But, we're just gaining some really, I think I've heard it said, unprecedented insights into, the unique specifics of tumors, allowing us to develop those targeted therapies. So, those of you listening, you may have heard of terms like tailored or personalized treatment, and these advancements are really what are at the forefront of our discussion today with Dr. Bookman. So let's go ahead and get started, Dr. Bookman. I know we won't have time to go into all of the exciting updates that are happening in the field. You and I discussed some things offline that were, top of mind that we really wanted to relay to the audience. So let's just start off with the first question I have for you, and that is for those who are, maybe newly diagnosed with ovarian cancer, is there any updates to that field, to that population of patients, and regarding, any updates and treatments or research that we should know about in that area?
Sure. I mean, there's been a lot of research activity, but right now it hasn't really changed what our routine standard approach would be. We still see a very important role for cytoreductive surgery as well as chemotherapy and integrating the two things together. And for patients where it's appropriate, then to consider frontline maintenance with an oral PARP inhibitor, particularly if there's a germline or somatic mutation in BRCA1 and 2 or related genes or evidence of homologous recombination deficiency or loss of heterozygosity. And I'm sorry to throw around those terms, but
Big
if I
words.
use if I use the abbreviations, not everybody's going to know what I'm talking about. So I'll mainly spell it out. But and where we've kind of not made that much progress is really integrating immunotherapy. We've tried hard. We've looked at frontline treatment, maintenance treatment, treatment of recurrent disease. It's really still an area in ovarian cancer that has not yet matured. I think what we've learned is that ovarian cancer can be very challenging in terms of how it can regulate the immune response in different ways. So just using a standard checkpoint inhibitor drug like pembrolizumab or atezolizumab or dostarlimab, something like that in and of itself isn't going to work. And even combining those drugs with PARP inhibitors, there's not a clear signal yet there. And so we're working on other signaling pathways that may make it easier to integrate immunotherapy with our frontline treatments. But right now,
Mm,
standard frontline treatment has not changed that much.
not changed that much. And PARP inhibitors are still the way to go, still beneficial, and we're seeing a lot of good progress with that. Is that correct?
Yeah, all the studies with the PARP inhibitors as a maintenance
Great.
treatment
Ma-
have been successful, and we now have mature data with olaparib, rucaparib, niraparib, veliparib, which is not FDA approved, but It's very consistent data. They all work pretty much the same way. A lot of similar side effects, but with some differences between the drugs.
Sure.
And currently, the question that we have is really who should get a PARP inhibitor as part of their frontline maintenance and who should
Mhm.
not. Because right now we don't have a perfect test to tell us which tumors are going to respond and which patients are going to benefit. Because
Right.
things that are reported to show HRD or LOH, they're actually not that informative in telling us whether a PARP inhibitor is going to work,
Going to work. Yeah.
because they measure the HRD or LOH status at a point in time from the past, not actually a functional test telling you what's going on today. So, I mean, just so you understand the magnitude of that, roughly half of ovarian cancer patients with high-grade serous cancer, which is the most common type, or high-grade endometrioid, about half of those will have evidence of homologous recombination deficiency, or LOH, and might benefit from a PARP inhibitor, but half of them don't. So right
Mm.
now, today, if we treated everybody, which is what, of course, some of our sponsors would like us to do, it's potentially half the patients would not be getting any benefit from the treatment. So that's where we have like a real biologic
Yes.
knowledge gap right now. We need
Yeah.
assays that are more predictive for how to use these drugs.
Yes. Okay. Yes. I remember recalling that from my time there at SGO was, we're giving it to everyone, but we don't know who actually it really impacts the most. So looking
Right,
at that gap.
especially in a
Okay.
maintenance setting, because there's nothing to monitor. Like if you're treating
Right.
somebody who has disease, and that can be done in maintenance, but it's in a partial response setting. Yeah, you can follow the CA-125, you can look at scans or exam, and then you know if you're having benefit or not. But many of our patients, over 80%, will be in clinical complete remission with nothing on scan, nothing on exam, nothing on the CA-125. So really, we're kind of just treating them blind. But fortunately, these are drugs that even though they have some chronic toxicities, they're things that we can usually manage with our patients. And I guess it's right now a little bit up to clinical judgment. What does the patient have in terms of their goals? What does the physician provider team have in terms of their goals? And what's the evidence? And it's an individualized decision for each
That's right.
patient.
That's right. That's right. Thanks for pointing that out. That's really
Yeah,
important. Yeah. Yeah. Okay. So something else that I could kind of gather from attending SGO, this being my first time to attend as well, and doing my own research after, it seems to be a number of exciting advancements that have taken place, are taking place, and some things that look very promising to discuss. And I believe a lot of our focus is on the topic of what we call ADCs, or antibody drug conjugates. For those listening, could you kind of tell us what an ADC, or an antibody drug conjugate, is, why we're looking at those, why it's so exciting, and maybe just kind of talk a little bit about what those are for us?
sure.
Thank-
These are not new. People have been working on this idea for
Yeah.
about 40 years, but it took a long time to find the right antibodies, the right drugs, and how to link them together in such a way that they would work. So now, for the first time in the last 3 years, we're really seeing successful antibody drug conjugates that are being used in clinical trials and
It takes
now
time. Yeah.
approved by FDA, and we're using them in our patients. And the idea is the analogy that's most commonly used is to think of it as a Trojan horse. For those of you that know your Greek mythology, but it's so the idea is that the antibody recognizes the cancer, sticks to the surface of the cancer, is then internalized within the cancer, and at that point, the chemotherapy drug is released inside the cancer cell, and most of it stays in the cancer cell and will actually, exert the toxicity that you'd expect from the chemotherapy. Some of it does get loose, and so you can still have regular side effects that you would see with any other conventional chemotherapy. But usually, the effects against the cancer are more dramatic and potent than the effects against the patient. But
Mm.
people can still have problems develop, like neuropathy, or have loss of hair, or have skin rashes, or other side effects, diarrhea, constipate, things like that, so not all of the drug is hitting the tumor, but we're trying to get as much drug into the tumor as we can. And so this is really an exciting area. Now, the thing about these antibody drug conjugates is that in theory, they only will work if the antibody can actually recognize an antigen on the cancer cells, stick to it, and then that triggers the internalization. So but they're all a little bit different, and it's really
Yeah.
been challenging for us to learn how to use them. For example, the real point person and ovarian cancer is mirvetuximab soravtansine, which binds to the folate alpha receptor, or what we call FOLR1. And we can measure FOLR1 on the surface of ovarian cancer cells, and it tends to be expressed in about 80% of tumors with high-grade serous cancer, but
So
some more than
80%,
others.
80, oh, okay,
Yeah,
80%
but
express
some
that. Okay.
but some more than others.
Got it.
And
Got
this
it.
is where it gets tricky, because the
Yeah.
data that for this particular ADC are that it works best if there's high level expression on 75% of the cells or more. And that only occurs in about 20 or 25% of tumors. So a
Mm,
lot of patients will have tumors that will have some degree of the
okay.
folate receptor expression, but not at the 75% level.
Enough to
And then
warrant.
that becomes a clinical judgment,
Mm.
the FDA approval, the clinical trial data support using it when there's high level expression. But we also know it does work in some cases, even at lower levels of expression, but we don't today have clear guidance on where we should be drawing that line. And right now the line stands at 75%. But that would vary a little bit, as we learn more about the antibody and how to combine it with other drugs and so on.
And that
In
was Ella here,
contrast,
correct? Was that correct? Was
yeah,
that Ella? Okay.
yeah,
Ella here. Okay.
yeah. In contrast, there's trastuzumab deruxtecan, which is in HER2, and that's a
Okay.
really fascinating ADC because it reacts with HER2, which is a protein, a growth factor receptor that we've known about for a long time. It's on many different cancers. And in
Yes.
some cases, it's a driver for the cancer, and particularly for breast cancer. Usually
Right.
not for ovarian cancer, but it's often expressed on ovarian cancer cells, but not at high levels.
So it's a
But it turns
protein that's overexpressed in the cancer cell that can cause the cancer to kind of thrive or whatever, maybe. Is
in
that
breast
right?
cancer.
Oh, in breast cancer. Okay. Okay.
Yeah, in ovarian cancer, it's there, but it's
It's
not
there.
doing very much. It's just a normal cellular protein. It's not mutated. It's not, changed in any way. It's just there. So, but it's not found on too many other tissues. So it's a target that can be used to differentiate cancer cells from non-cancer cells. And so the antibody recognizes HER2, will get internalized, release the toxin. And the interesting thing about in HER2 is that it works even if the HER2 expression is very low.
Mm,
Like here, we measure that by immunohistochemistry, where we stain the cells. So
mhm.
we call it either 0, 1 plus, 2 plus, or 3 plus. So if it was first tested mainly in 3 plus, then 2 plus, 3 plus, and then we started getting data on 1 plus, and now there's even trials going on that are measured as 0, because even if the stain shows no staining, there still could be HER2 on the cancer cells because the stain has a certain threshold of sensitivity. And so we're eagerly awaiting the results of those trials. I mean, I've treated a number of patients with 1 plus expression on their tumors, both endometrial and ovarian, and have seen some very dramatic long-term responses. I mean, so this is a very real phenomenon. It is different from the folate R1 receptor expression and the mirvetuximab soravtansine, and all of these are going to be different. So we're going to
All
have
of
to
them are
learn
going to be,
about
yeah.
each one.
Okay.
So
Right.
HER2, yeah, so in HER2 recently got approved for tumors that express HER2 regardless of histology. So if your tumor has HER2 on it, then that might be a treatment that would be available in the future for
And
you.
that treatment is called
Um,
again, is called what again?
and HER2, ENHERTU, that's the
And
brand name.
what's the treatment called?
And HER2,
Oh, that is the treatment name. Okay. Got it.
yeah,
Okay.
HER2, it's confusing, isn't it? Yeah.
I was
So
thinking
HER2,
trastuzumab or
no, yeah, well, it is. It's trastuzumab deruxtecan. It's the
okay, that's what I
original HER2 antibody that conjugated with an. So, yeah, it's complicated. The antigen is called HER2, HER2.
correct.
The drug, the brand name is Enhertu,
Okay.
ENHERTU.
Good to
So
know.
they've named the drug to match the target.
That makes
Now,
sense.
it makes sense, but I don't know what I should be calling it when we're talking about it, but leave that as it is. But the interesting thing that's also different about Enhertu is that the toxin, the chemo drug, is completely different.
Mm,
It's a camptothecin analog, and camptothecins were first developed from the leaves of and blossoms of the Camphotheca acuminata tree, or an empress tree in China. And it's related to topotecan and irinotecan. It inhibits an enzyme called topoisomerase 1. We don't use those drugs very often in ovarian cancer at this point in time. So it's very exciting that this particular ADC uses a drug that the cancer may not have seen before. So the cancer may actually be more sensitive to the topotecan analog than it might be, for example, to some of the other toxins. And then to complicate it just a little bit further, there are also ADCs that target other antigens, such as TROP2, which is TROP2, and that's called sacituzumab govitecan. And that also can be used in ovarian endometrial cancer and is being studied in trials to do that. It's not FDA approved in that setting, but it's being evaluated. And the interesting thing there is you don't have to measure whether or not there's TROP2. You just can treat the patient and assume that there's enough TROP2 where it will work.
Wow.
Because they've done prior studies showing that measuring TROP2 doesn't make a difference. It doesn't predict how well it's going to work. So we see all different scenarios. One where you have to measure and it has to be high. Another where you measure and it doesn't matter. And another one where you don't even have to measure. So over the next 3 years, watch this space, because these things are going to keep evolving and providing new treatments for our patients.
And possibly more markers, right? Gosh, this is
Yeah,
exciting.
and then
Yeah.
and also move them more into maybe even frontline setting in some cases
Right.
if they're really good.
So I know a lot of our audience has probably heard, the term biomarker in tumor testing. So how important is, biomarker tumor testing in the context of finding, maybe, if I'm saying this correctly, finding these targets or these points of interest, and what should patients know about biomarker tumor testing?
Well, so that is a complex question, and I'm going to break it up into little pieces. So
Okay.
first, think about the frontline setting, newly diagnosed and
Right.
planning treatment. Their biomarkers really don't make a difference. I mean, we treat all of our patients with high-grade serous cancer pretty much the same.
Same. Mm-hmm.
So even if we knew there were certain mutations, or it didn't have certain mutations, or has LOH, or it doesn't have LOH, those are things that are more useful in managing recurrent disease
Right.
or providing some prognostic information, but they're not going to change the primary treatment, which is still going to be, as of today, carboplatin, paclitaxel, and surgery, or a similar regimen. So, and with all the talk and all the testing and everything being done, it's not something that we absolutely need as part of frontline therapy. The first time that it creeps into decision-making has to do with maintenance.
Yeah.
Because you finished chemo, you've had surgery, and now the question is, as we said earlier, should you be taking a PARP inhibitor? So there we need to know, is there a mutation in BRCA1, BRCA2, RAD51C or D, or PALB2, or other genes that are kind of on that pathway? And we need to know, is that something you were born with, it was inherited, or is that something that just developed in the cancer?
In the tumor. Okay.
In the tumor. And then there are also other tests like the homologous recombination deficiency and LOH, which are imperfect tests, but also can give us some clues as to whether a PARP inhibitor might be useful.
Dr.
So
Pittman,
with that information, yeah, then you can make a more informed decision about whether or not to recommend a PARP inhibitor. So that's the first time in taking care of someone with ovarian cancer where that information really becomes relevant.
Yeah. Can you describe what LOH is, just to make sure we all understand what that is?
Yes.
Or what that
So
stands for? Or just what it stands for?
yeah, no, it's loss of heterozygosity. And what
Oh,
it is,
okay. Okay.
what it,
Yeah.
well,
Yeah.
what it is, I mentioned that earlier. No, it's you have to remember there's 2 copies of every gene. And this is a hugely important point, and people make mistakes when they're reading reports from the different molecular testing labs because they forget about this. And even the labs make mistakes, like they'll recommend PARP inhibitor because there's a BRCA mutation, but unless the BRCA mutation is also associated with loss of the second copy, then it's not pathogenic in that cancer, and they don't remember that part of the story. And what I mean by that is that the way the BRCA mutations become important is that they're broken, they don't work. So it's a loss of function. And if you have a second copy of the BRCA gene, well, then you get out of jail free. You have an intact protein that can make up for the broken copy. It's like having it's like having a flat tire, but you have a spare in the trunk, so you're all set. But then if the spare gets a flat, what do? Then you're in trouble. So you got to knock out both copies of the gene for that mutation to impact the cancer, and for that mutation to cause loss of heterozygosity and HRD, which is homologous recombination deficiency. And if you do knock out both copies, one with a mutation and one with a deletion, or two different mutations, then a PARP inhibitor will be really important and could really work. So it's a complex area. I've seen people make a lot of mistakes and assumptions about things. I often get referred patients because of their molecular pathology reports, and people are saying, well, it says there's a BRCA mutation. Shouldn't I put them on a PARP inhibitor? And I said, no, that BRCA mutation has nothing to do with their cancer. It's just a bystander. So it really depends on the context. And the context has become more complicated as we know more about the molecular genetics and things like microsatellite instability and DNA mismatch repair and Lynch syndrome. I mean, all these other conditions that can occur in our patient population. So I think that we're all struggling with this. It's not just patients and families, but it's care providers as well. We're being hit with the very detailed knowledge that not all of us have had good training on even how to interpret some of these things. So it's good to be aware of that.
Yeah. Lots happening. Yeah, absolutely.
And
Thank
so
you for
the
that.
other way that profiling becomes important, obviously, is like we were talking earlier with the antibody drug conjugates, is knowing if certain antigens are on the cancer cells so you can target them. So that's not related to next generation sequencing. You're not looking for mutations. You're actually looking to see, is the protein there? So that's just staining the tumor tissue and seeing if it lights up. It's a different sort of molecular profile. And then there's a lot of other things. That's just like scratching the surface of it, of course.
Sure. Ooh, okay. So maybe beyond ADCs, are there any other promising things that we're looking at on the horizon for ovarian cancer, such as I think there were some things discussed, what you call molecular drugs or other types of pinpointed targeted therapies?
Yeah, I mean, one of the interesting examples has to do with a protein called p53, and the gene for that is known as TP53.
I've heard of that, yes.
And p53 is almost always mutated in high-grade serous cancer. In fact, I mean, you can't really, in general, make a diagnosis of high-grade serous cancer without it having a p53 mutation.
Okay.
But there are hundreds of different ways the gene can be mutated, including just deleting it altogether. It's just gone, or mutations that cause different changes in function. But all high-grade serous cancers will have some defect in the p53 protein and the TP53 gene. So the question's always been, well, could we fix that? And historically, it's a lot easier to turn things off than to turn things on. So if you have a gene that's hyperactive, like your kids maybe, there is a medication in general that can turn that gene off. Not always, but often. And a lot of tumor mutations are associated with hyperactivity. But the p53 protein, it's the opposite. It's like BRCA1 and 2. You lose function. And so you would have to try to restore the function back to normal, which is a lot harder to do. I mean, you think about it's a very big molecule, very big string of DNA. If there's mutations in there, you can't just go into the DNA and fix the mutations, at least not with the tools that we have in use today. You have to go to the protein and try to refold it. So the protein's folded badly, it doesn't work, it's broken. But if you stick something in the middle of the protein that causes it to refold, all of a sudden it gets activity back. So there are a couple of different small molecules that have been shown to do that with p53. They can take a broken p53 and fix it. And one of those is being tested now in clinical trials, and there's some early promising data. But
Okay.
I think it's going to be a little tricky because even though the p53 mutation is important for why that cancer developed in the first place, it's not clear how important it is for things like ongoing treatment, resistance to chemotherapy, and things like that, because there may be many other genes and other pathways involved in those issues. So just fixing the p53 in and of itself may not always improve treatment or long-term outcomes, but that's what we got to figure out from these clinical trials.
Mhm,
So
mhm.
the Y22C mutation in P53, which occurs just a few percent of the time, that's the one that's specifically targeted with the trial right now that's going on with P53. So that's a long-winded
Ah,
answer to your short.
fascinating. No, it's just
Yeah.
fascinating how much insight we're gaining into these molecules and these drugs and these
Oh,
proteins.
yeah. Yeah.
It's just fascinating that, there really is something to look forward to in the future and today too. So
Yeah.
it's exciting.
Yeah. I think the other
Yeah.
area where I find the profiling to be helpful is because many cancers that involve the ovary didn't start in the ovary. So we know high-grade serous cancer probably starts in most cases in the fallopian tubes, but then
Mhm.
involves the ovary because the ovary provides a good home, has blood
Mm.
vessels, hormones, it protects it from the local immune system, etc. So, and we also know that endometrioid ovarian cancer is really endometrial cancer. So it's something that may have started in the uterus or associated with endometriosis, spread through the fallopian tube, get out and stick on the ovary and grow as a cancer. And for years, we were saying this was endometrioid ovarian cancer, as if the ovary could magically turn into an endometrial cell, like a uterine cell. But what it really is probably endometrial cells that escaped from the uterus, which we know they can do. They attached to the ovary and then they grew as a cancer. So
Oh,
we're now learning that we can apply some of the things we've learned about endometrial cancer to the
wow.
treatment of endometrioid ovarian cancers,
Wow.
including the microsatellite instability, Lynch syndrome, DNA mismatch repair, high tumor mutation burden, POLE mutations, all these different things that are very instrumental now in guiding the treatment of endometrial cancer are things we should be applying to some of our patients with ovarian cancer. So that's kind of a new twist, and not everyone's quite picked up on that yet, but I think it's going to be more important as time goes on.
Sure. That's very interesting. We had a question come in. I wondered if you wouldn't mind answering.
Yeah,
Going back to PARPs, the question is a PARP inhibitor effective if you've had a recurrence of ovarian cancer after a second chemo series of carbo and Taxol? Is that something that you can answer?
sure. Well, it depends. That's the
Yeah.
answer. So if you were taking the PARP inhibitor at the time when the cancer came back, then the cancer by definition would be resistant to the PARP inhibitor and you would not expect it to work. If, however, you stop the PARP inhibitor and then at some point in the future, the cancer came back, then you don't know. It's possible that the cancer might be resistant to the PARP inhibitor, but it might also be sensitive.
Mm.
So if patients go through chemotherapy again and get into a second remission, they could start taking a PARP inhibitor again. It's just we don't have really good tools that predict whether or not it's going to work. It's kind of we can try it and see what's going on. And this gets back to what I was saying earlier, that we need better tools to predict. Because wouldn't
Right.
it be nice when that happens if you could send off one or two tests, get some data back, and say, well, it was a good idea, but we wouldn't expect it to work, or yes, this should help you, we should do it, because there are at least 10 different ways that cancer cells can get around PARP inhibitors,
Oh, wow.
including secondary mutations that fix the broken BRCA gene. There's just all kinds of things that they can do. So some of those things we can test for, but there aren't really readily available commercial tests that will do that routinely. It's more
Okay.
like research-based testing. And so we need a push to kind of move some of those test techniques from the research lab into the commercial labs, because they would be very helpful in terms of guiding treatment decisions in cases like that.
Okay. Well, thank you. Thank you. And one other quick question. You had mentioned the HER2 protein and the treatment called Enhertu. Is there a name for, or do you know that, or can you tell us the name of the trial that is investigating the Enhertu,
Whoa.
or that's a part of?
Well,
Ah,
the trial was Pan Destiny 2,
that's right.
where
Pan Destiny 2.
Pan Destiny 2, where multiple tumor types were evaluated to see if they would respond, and they
Okay.
looked mainly at 2+ and 3+ staining. and they included ovarian, endometrial, and cervical cancer in that series, and they did have
Okay.
responses in those groups. But to me, the most interesting trial is the status trial, STATICE, which was conducted by the Cancer Institute of Japan, the Japanese National Cancer Institute. And that was limited to patients with carcinosarcoma, which is a very aggressive tumor, hard to treat, can develop in the ovary, but also in the endometrium.
Mm,
And usually drugs just don't work in carcinosarcoma. It's usually resistant to most treatments.
mm.
And that trial, even though it was fairly small, it included the 1 plus HER2 as well as 2 and 3 plus. And in the 1 plus group, the response rate was 70%. I mean, we have
Wow.
never had a trial
Wow.
that had data like that before in such a difficult to treat disease. I mean, if I was on FDA, I probably would have given accelerated approval based on
Mm,
that small study because that's just such an unexpected result, basically.
yeah, very.
But and I can tell you, we've seen that that is accurate. I mean, we've had success using it in similar situations. So I think that that's a good example right there.
Okay. Thank you for that. We've got about 10 minutes left. We're going to go a little over today. And before we end, I wanted to hit on two more topics here. One was, we get a lot of questions about, the different rare ovarian cancers that exist. And if there was anything that we've learned or know newer this year regarding any updates to maybe low grade serous ovarian cancer or any of the other rare ones that stood out to you.
Yeah, I think first off, what I said earlier, that many cancers that involve the ovaries started somewhere else.
Sure.
So in addition to that, applying to high-grade serous and endometrioid, probably most mucinous tumors started elsewhere. It could include the endometrium. Clear cell tumors are related to endometriosis and related to the endometrium.
Sure.
And
Wow.
that's the list goes on. But low-grade serous cancers, those probably of all of them, may be the most likely to actually have originated on the surface of the ovary, because we don't usually see precursors for low-grade serous cancer in the fallopian tubes the way we do with high-grade serous cancer. But that's an open question. And low-grade serous cancers are don't have the mutation in TP53 or the P53 protein. So that's the main way, like under a microscope at low power, you can tell that it's different, and at high power, you can tell even more. But the best way of distinguishing a low grade from a high grade serous cancer is testing for the P53 stain, which is very reliable. And so they have a whole different pathway going on there because the low grade serous cancers are not related to BRCA1 and 2. They don't run in families. They tend to be sensitive to hormones, and we've
Okay.
now gained increased use of hormones for managing of low grade cancers. And they also have activation of a different pathway. Instead of P53 or homologous recombination deficiency, they have activation of a pathway that usually depends on a mutation or activation of the KRAS gene, KRAS, or genes related to KRAS. So completely different at a molecular level from high-grade serous cancer. And so we need different treatments. Chemo does
Mm,
not work that well in low-grade serous cancer. It may work once or twice and may get some response, but it doesn't work the same way that it works in a high-grade tumor. So and I already mentioned hormones. So the new thing is really to target that activation in the KRAS pathway. And we've had drugs that can do that called MEK inhibitors, MEK inhibitors, but they're not very specific and they can have a lot of side effects, and there's pros and cons. They don't always work that well. The tumors go around them. But there's some new drugs that block multiple parts of that pathway all at the same time. And when you do that, you get a much higher response rate, like more in the 60 to 70% range rather than the 20% range. And so those drugs are under active development. They've done non-randomized trials, and they've moved into a phase 3 randomized trial called RAMP 301.
right.
And we're hoping maybe in 2025, we will hopefully have some regulatory approval for these drugs so we can start using them. I actually have patients today who are waiting for those
Wow.
drugs to become available.
Sure.
Yeah, so we're very excited by the early data, which looks very strong. I mean, I think it's got a very high likelihood of success. And I wish the drugs were available now. I mean, I wish we had a more streamlined review process for some of these things.
Sure. Right, right. Okay. The last topic that I'd like to hit on, because we're getting a lot of questions regarding liquid biopsies. And I know that this is a very popular, very controversial topic right now, this topic of liquid biopsies. Some of you may have heard of things like ctDNA, cfDNA. What does all that mean? But could you define for us what these are, what their current use is in the field of cancer, and then how in the future it might pertain to ovarian cancer? I think that would be very helpful.
Yeah, I mean, it's an emerging field.
An emerging field, yep.
Basically, we already know that cancers often have mutations associated with their development, and that when you send off tumor tissue to do a molecular profile with next generation DNA sequencing, you identify the different mutations. And one of them, we've talked a lot about is the P53 or TP53. So if you know that a tumor has a certain mutation, potentially you could just collect the blood and look for circulating DNA that matches that mutation. And that would tell you whether or not there are any residual cancer cells in the patient in
Okay.
simple terms. But it's not that simple, of course, because you can have benign tumors that might have the same mutation and haven't transformed into cancer. So
Okay.
you might find it in the blood, but it has nothing to do with the cancer. So you have to look at it in many different ways to figure that out. And the other is just because you find it in the blood, how does that change the way you take care of the patient? We know from retrospective studies in cervix cancer, endometrial cancer, and now in ovarian cancer, that if we track these things, they are prognostic. I mean, they tell us that certain patients are more likely to have recurrent disease than others. So if you do surgery and chemotherapy and you remove the cancer and you're in remission, and if that blood test is negative, then you're in a better group. But it's not guaranteed. You can still recur at some point in the future. If you do all those things and you do the test and the test is positive, well, you're in a group where you're more likely to recur more quickly. But what it doesn't tell you is what to do today. It doesn't tell you that if you start treatment this afternoon, that you would live longer, better than if you just waited 6 months until something showed up on a scan and you needed treatment at that time. So those studies have not been done. So right now we can say that the test is accurate and it measures the things that they say that they're measuring, but they have not shown that it has any benefit to patients or to help us make better decisions about treatment. And that's because none of those trials have been supported by the different companies that have come forward with these assays. So they have, it's confusing because their assays have been FDA approved in some cases and covered for insurance or Medicare for patients. And that's because the way that tests are approved and covered is different than drugs. I mean, we can't get a new drug approved, like I just told you about the low-grade serous cancer, until we show that it's safe and effective and makes a difference, and we should have that
Meaningful.
drug available,
Yep.
right?
Right.
But you can get an assay approved just by showing it measures what you said it measures.
Right.
And it might have prognostic information, but it doesn't tell us how to actually use that information to take better care of patients. So right now, my answer to that is I don't order those tests for anybody. I haven't yet. And it's not just ordering it once, because then you're obligating to order it multiple times over a course of a year, let's say, to track. It's like
And
kind of following the CA-125, but maybe
sure.
doing it at a more sensitive level. And we already know that the CA-125 has a similar pitfall. I mean, if
Yeah.
the CA-125 is very low and slowly rising, like it's going from 10 to 12 to 15 to 17, well, maybe that's telling us a story, but it doesn't tell us how to take care of the patient. We still have to use clinical judgment. We still have to do scans. We still have to talk to the patient. We have to figure things out. So it's
Mhm.
kind of like a very sensitive version of the CA-125, where as of today, we don't have enough information to know how to use it.
Yeah. So don't have enough information, and we also don't want to increase the anxiety and worry of our patients, right?
Oh,
Without
yeah.
knowing how to use that information appropriately. So
Oh, and it comes up all the time.
yeah.
I wish the companies would get
I
together
wish
and
we could do it
sponsor
today. Yeah.
some good trials because we'd have a lot of people interested in supporting the
In the
trials.
trials, yeah,
Yeah.
absolutely.
I
Yeah,
mean, as a word of caution, I mean, this was studied with CA-125, and earlier treatment did not lead to better outcomes. It actually led to worse outcomes because people were on more drugs for a longer period of time and had more side effects.
hmm
So, I think we really need to know when to intervene and how to intervene before we can use that kind of information.
yes. And hopefully in the future that'll be something that pans out.
Yeah,
That would be great. Yeah.
yeah.
So as we wrap up, what could I ask you? What message of hope or encouragement could you share with our audience, especially those who are impacted by ovarian cancer, with all of this
Yeah.
exciting stuff that's happening?
Yeah, I mean, we have more resources and
We do.
tools to use than we've ever had before, and it's still increasing.
We do.
Um, and we've touched on many of them: PARP inhibitors, antibody drug conjugates, profiling, where that's helpful. And so, there's a lot more we can do for people than when I started doing this 40 years ago.
40 years ago,
But
yes.
yeah, but and so I think that I've just been very excited of all of these things so far by the antibody drug conjugates. I mean, I've literally had patients that I was talking to about, discontinuation of therapy, transitioning to hospice after multiple lines of treatment and resistance to treatment. And then we test their tumor and it came back positive for HER2 or folate receptor, and then things just turn around. I mean,
Wow.
people who I would have put on hospice who then were taking trips with their family and doing all kinds of things. So, and sometimes that's been good for over a year,
Mm,
which is a gift.
yeah.
Now, I mean, again, I've been practicing for a while. I've not been in a situation like that before. That's brand new.
Appreciate you sharing that.
Yeah.
Absolutely. Well, thank you so, so much for your time. It's been a privilege to delve into these topics with you. And for those that are, seeking more information about these topics, we will list some resources in our video description when we post this up. So stay informed, stay hopeful, and thank you for being an important part of this discussion. We really, really appreciate it. Thank you.
And thank you, NOCC.